So my talk is basically a combination of Vijay's talk and Pradeep's talk. I have taken a bit from Pradeep's talk. I have taken a bit from Vijay's talk. That is what is permislet. Permislet is a combination of perfect technique and the mini slit. So I have taken per from perfect, and mini slit, of course, I have taken into it. So why this concept has come? This concept has come basically, I think Vijay may be knowing this. This is in RR only this concept has come. 61 years old female has come to us, and she had recurrence with pterygium twice, underwent the gold standard procedure, that is CAG twice elsewhere, again had recurrence. And she's also a known case of primary open angle glaucoma. So she told us that it's not possible. I did not want any further recurrence. That's what her comments were. So definitely, is there any answer to that? Can we afford to give a zero recurrence to a person who has already suffered by repeated pterygium surgery, and even that pterygium surgery has led to the symblepharon formation? She had ocular restrictions also. So yes, there is an answer, and this is what is the perfect technique. But the issue with perfect technique, what Vijay has brought out, is that we have to retrieve a very large conjunctiva, because we have to cover from limbus to medial canthus. And in bargain, what might happen is one can touch onto the tenon that leads to the fibrosis. And since she's a patient with glaucoma, so if she, if in future a trabeculectomy is being planned in her, then it would be little difficult, because there may be failure of trabeculectomy because of fibrosis. So can we advise this technique in this patient? Of course not. So what we did, we thought of it, we modified this perfect technique to permislet. So what we did, what Vijay has highlighted, we did that as a pterygium extended removal. We extensively removed the pterygium from the limbus till medial canthus. We exposed the entire, medial rectors, but instead of putting the graft, we placed the amniotic membrane and we placed the limbal pieces. And this is how we evolved this technique as permislet. And what we found that the post-op follow-ups, we have seen wonderful results with this technique. So far, we have done 5 cases, and we have found zero recurrence. So this is how it looks from the beginning to the end. And even you can appreciate that there is no symblepharon now, and the ocular movements are full. The only issue was with this, because Sanjay was involved in it, so he was very fond of doing all this. So he said, sir, there is 2 prism diopter of PBCT. Maneka, it's okay. 2 prism diopter is acceptable to us. Then these are the results of the further 3 more cases we did. In one of them, we had the granuloma formation. Otherwise remaining, we excised this granuloma, and subsequently the patient was fine. This is the patient with double head pterygium. We adopted the similar technique, same technique in this patient. And this is after 6 months, we can very well see that there is no recurrence and there was no ocular restrictions. So I have already told the thought process, how was it evolved. So when it was evolved, when the patient was after us that she wanted a recurrent-free surgery. So what we did in that evening, we reviewed the literature. And when we reviewed the literature, we found that there was an article from Dr. Hurst from Australia that perfect technique gives almost zero recurrence. That is 1 in 1,000 in primary pterygium. So further review of literature has found that even in recurrent pterygium, there was no recurrence with this technique. But the issue was very clear. We cannot afford to sacrifice such a large conjunctiva. So that's how the technique was evolved from perfect to permislet. And this is how it evolved. This technique provides most of the pros of both these 2 techniques, perfect and mini slit. Like we have complete and extensive removal of the pathology. In addition to that, we are preserving the conjunctiva. We are offering a very good anti-inflammatory benefits of amniotic membrane, and we have achieved replacing the pathological stem cells with the normal. So we are mostly combining the pros of both these procedures. This is a short video which I would like to show you this technique. This is a video we did at RR Hospital only. You can see that since there were a lot of adhesions, so we started from the head, and this is what we are removing, the sembliferon. If you look at, this is a thick fibrotic tissue under the conjunctiva. And then this step is, I'm not doing this step. This is basically Sanjay who is doing this step. So I took the help of squint specialist in this. And he has very well exposed the medial rectus. Now there is a perfect, now this is the, our oculoplastic surgeon is doing this. This procedure, I remember Sonali was doing this procedure. It's phonics formation. So we three combined actually this procedure. Then now my turn came and I put, amniotic membrane. And did the mini slit as was described by Pradeep. We placed these pieces at the limbus, made them adhered with the fibrin glue, and then subsequently we placed the bandage contact lens. So we had hindrances in form of exophoria, but that exophoria is, it's not very great. Granuloma we had in one patient, and this we subsequently excised. So what is most satisfying is that there is no recurrence with these 5 cases till now. There is no sembliferon reformation in the first case. A good cosmesis is there, and we haven't found any ocular restrictions. And the most important, what evolved around the thought process was that the conjunctiva preserved for, if at all, future glaucoma surgery. So this technique seems to be beneficial in patients with recurrent pterygium. It needs to include more patients to finally conclude the results. Thank you.